dispatches tonight a story of hope for Africa. A report that suggests that Africa may not, after all, be in the grip of a devastating AIDS epidemic. For years now, Western scientists have predicted an AIDS catastrophe for the continent. But tonight, reporter Joan Shenton travels Africa east and west to assess what is really happening on the ground. Are there any reliable statistics? What do doctors and health officials in Africa believe? And what does this say for our understanding of AIDS as a whole? Tonight's dispatch reveals the puzzles and contradictions of AIDS and Africa.
The death drums, played nightly after the news in Uganda, sent a chill of fear through the people. For a period, these funeral drums were used to tell them what would happen if they made love to someone new without using protection. HIV would get them, AIDS would kill them. The picture of AIDS in Africa has been one of unremitting horror. The World Health Organization describes sub-Saharan Africa as having the highest rates of HIV infection in the world, an estimated 1 in 40 adults, and predicts that by the end of the century there will be 500,000 deaths a year. Academic articles like these by Professor Roy Anderson in the UK are currently stating that AIDS will bring about a decrease in population in a few decades, and this will lead to political disturbances in the continent of Africa. The heterosexual transmission of AIDS through unprotected sex is blamed for the spread of HIV and AIDS. Health education now teaches school children of the dangers of sex without a condom. Uganda, struggling to rebuild itself after 2 decades of civil war. A country that can only afford under $1 a year per person in health care opened its arms wide to international aid agencies. But the ensuing flow of often exaggerated aid statistics that emerged from a multitude of Western research projects has backfired.
I am concerned about the interpretation of the picture of AIDS in Uganda, and this is unfortunately arising from our strategy of coming out and speaking openly about this disease, while some other countries have preferred not to publish the actual situation.
I think there has been of late a lot of exaggeration about the extent to which AIDS is affecting Africa and Uganda in particular. I think one of the reasons is that we have been very open. We are the first African country to come out very openly with the program, and this has somehow been misunderstood by some people from developed countries, especially the uninformed press, that this is the epicenter of AIDS. I don't think that's the problem. I don't think that this is the epicenter of AIDS.
People are trying to make a way of living out of this. You know, they think that if they publicize it and they exaggerate, they might win sympathy of the international community and get AIDS, or rather get assistance from the... We need assistance, but not through the other way. I mean, not through bluffing people, that the people are dying at the rate which is not true.
From both my literature review and my personal experience over most of the AIDS, so-called AIDS centers in Africa, I can find absolutely no believable, persuasive evidence that Africa is in the midst of a new epidemic of infectious immunodeficiency.
So is there an AIDS epidemic? If not, how is it people are being misdiagnosed? This is the village of Rakai, described as the epicenter of the AIDS epidemic. Villages like this, we're told, have been wiped out by the disease, and AIDS is said to have started here, going on to infect the whole world. Najemba is a typical victim of the AIDS panic. People think she has AIDS, although no one has ever tested her blood. Like so many thousands, she's an AIDS case without any evidence. She is struggling to survive, but that's just as likely to be because she's starving, living off scraps from her brother.
I can hardly feed myself according to the salary that I get. That means I'm running poverty. That's why you see me sleeping in such a thatched house, which is not good for my life. So now my worries is poverty first. Secondly, I lack food. Thirdly, we don't get good water. We don't get medicine. We don't get, let me say, something that can keep someone alive.
Gerald, his sister and his family are locked into a cycle of poverty, acute food shortage, dirty water and disease. In Africa, there are few places where HIV tests are available, but on the basis of her symptoms alone, Najemba still qualifies for an official AIDS diagnosis. She's suffered combined symptoms of fever and diarrhea for over a month, and she's had a dry cough.
How do you feel? Do you think you have AIDS?
When we first met Najemba 2 months earlier, she had such bad infections on her legs, she couldn't walk at all. There was no way she could possibly afford any antibiotics, so we left her some money for medicines, and the leg infections have almost dried up.
A bit higher? Yes.
And then after this, as you saw her the other time.
Can I see the other leg, Najemba? That one is better. That one's better. And this is better than in October, isn't it?
The fact that Najemba hasn't been able to pay her rent, combined with the belief that she has AIDS, means she is now being forced out of her home in the village. In her fragile condition, she's been trying to build a makeshift shelter in a malaria-infested banana grove. She has in fact been building her own tomb. If Najemba dies, her death will be blamed on AIDS, but the real cause is more likely to be the destitute living conditions in the Rakai. In Najemba's village, the total breakdown of the health and medical services is only too apparent. We visited the local hospital in this so-called epicenter of AIDS and found a sorry scene. Not a single AIDS patient, only an empty ward. No nurses, no doctors, only one tiny baby suffering from malaria convulsions, surrounded by her silent family. We then found the only member of staff who got up from her sickbed to speak to us.
I work as a midwife, and I also help in the treatment of other patients.
How do you feel?
Now I'm sick.
What do you have?
I have malaria.
Lack of staff and medicines at these local hospitals and dispensaries has meant that sick people simply stay in their own homes. But Nurse Maxensia did agree to show us the medicines cabinet, stocked with some drugs supplied free under the World Health Organization Essential Drugs Program. However, under a new cost-sharing scheme, villagers are now asked to pay a fixed rate for them, which for most means going without.
Some don't even come. Before we put up that system, we used to have a lot of patients here. A full day we would work about 150 patients, outpatients, without counting the inpatients.
But now?
But now we get few.
Because they can't afford to buy.
They can't afford to pay.
Our journey through Uganda took us through the Rakai region to the town of Kyotera. We travelled with Ugandan radio journalist Sam Mulondo, who's been covering AIDS stories both in his country and in Europe. Here, it seems that the fear of AIDS is having as great an effect as AIDS itself.
People are dying psychologically. Their T4 cells, scientists call it T4 cells something, psychological death. Many are dying because of that. Somebody gets simple malaria. He fears to go to a doctor, see a doctor, just because he will be branded this clinical case as an AIDS or HIV. People are just left at home. They don't go for any treatment whatsoever. Any slight infection, people don't go to hospital. In addition to this area lacking proper medical care facilities, people are worried about the water they drink. They don't have treated water, piped water. It's only from the springs well, which is contaminated. As it rains, all sorts of, contamination goes into the springs and wells. They simply pick that water through these little jerry cans, plastic things, take home. Most of them, they don't boil that water, they just drink it.
At Uganda's capital, Kampala, Mulago Hospital's long tradition of excellence in tropical medicine has made it a focal point for AIDS research programs. Here, as in all African countries, HIV tests are too expensive for general use. AIDS is diagnosed through guidelines laid down by the World Health Organization, known as the Bangui Clinical Case Definition. To qualify for AIDS, someone must have a combination of symptoms, like persistent diarrhea and fever for a month and a dry cough. The trouble is that many of these symptoms are indistinguishable from those of old established diseases like TB and malaria. The Ugandan Ministry of Health did not allow us access to film patients inside their hospitals. They were concerned about patient privacy and the projection of too many negative images in the West. But we were able to speak freely to the doctors. At Old Mulago Hospital, Dr. Martin Okoton Wang is in charge of the TB wards. He's concerned about the way African statistics are being wrongly reported. TB is a disease that occurs where there's poverty, malnutrition and lack of medicines, conditions all rife in today's Uganda. Figures have doubled recently in these wards.
We have just recently undergone through a series of wars in this country, and this has led to a breakdown in our health services. It's not unknown that following wars or famines, increases do occur, particularly in infectious diseases or communicable diseases, of which TB is one of them.
The rise in TB cases in Africa has led some scientists to speculate that the HIV virus is making some people more susceptible to the disease. But it's hard to find any evidence for this. What is documented is that flaws in the clinical case definition, that is the combination of symptoms used for diagnosing AIDS without an HIV test, have meant that many TB cases have mistakenly been called AIDS.
A patient who has TB and is HIV positive would appear exactly the same as a patient who has TB and is HIV negative. Clinically, both patients could present with prolonged fever. Both patients present with a loss of weight, marked loss of weight actually. Both patients would present with prolonged cough, and in both cases the cough could equally be productive. Now therefore clinically I cannot differentiate the two. Even when I look at the blood, I may find some similarities still between the two groups.
In the past, TB of the lung or pulmonary TB was not considered a disease that qualified as AIDS by the US Centers for Disease Control, but it was added to their list in January this year.
I think if they could include pulmonary tuberculosis as AIDS defining case, then all the TBs in Africa will, almost all the TBs in Africa will be AIDS.
The danger in calling all TB cases AIDS means that money badly needed for the treatment and cure of TB is being diverted into preventing the spread of HIV.
I think that there's a lot of attention that has been paid to HIV and to the detriment of many other diseases, and as less and less money becomes available, these diseases themselves could become a public health hazard. Malaria, we are seeing a resurgence of malaria.
Malaria is quite a very big problem in Uganda. It's the commonest disease in all parts of the country, and it's the commonest outpatient problem in all the health units in this country.
Is it curable?
Very much so. It's very curable. The drugs are available. Chloroquine, which is still the cheapest, is still effective.
Are you able to supply the medicines that are really needed?
The supplies of medicines are not actually adequate in most health units.
Are you worried that the funding for AIDS is taking money away from the badly needed medicines for TB and malaria that are the biggest killers, because the funding for AIDS is limited on the whole to counseling, to education and to condom supply, but not to medicines?
That's a very important point. In fact, we have periodically emphasized that research of any kind, not only AIDS, should have a component of patient care. While we do agree that there should be change in behavior, and that's a very important strategy, but it would be ridiculous to leave people to die of tuberculosis.
Are you able to persuade the foreign agencies to provide funding for medication, or are they reluctant?
There has been little compliance on the side of actual patient care. We are having a lot of problems.
Our search for the best documented data on HIV and AIDS took us across Africa from east to west, 3,000 miles to Côte d'Ivoire. Its capital, Abidjan, has been chosen by many international agencies to further research into HIV. A stable political environment, well-developed health services infrastructure, meeting place of different cultures, and busy tourist trade have made it a useful center for research projects. Professor Cassie Manlong is Côte d'Ivoire's Director General for Health and Social Services.
La situation en Côte d'Ivoire de l'infection à VIH et du sida est la plus importante en Afrique de l'Ouest, puisque nous sommes classés au 6e rang des pays africains aussi du Sahara. Et nous sommes les premiers en Afrique de l'Ouest pour la prévalence.
In Abidjan, epidemiologist Dr. Kevin de Kock heads a $2 million a year AIDS research project funded by the U.S. Centers for Disease Control, or CDC. He's convinced there's a mounting AIDS epidemic.
The problem is actually it's under-measured. If you don't measure how changes in how patterns of mortality, for example, are changing, you won't know. We've looked at it in Abidjan, and they've changed extraordinarily since the AIDS epidemic, with a tremendous increase in death, in premature death. This is an epidemic of historical importance. It's an epidemic that's going to last for decades. It may last more than a century.
Prophecies of doom for Africa should perhaps be judged against similar predictions that have long been made of an AIDS catastrophe in the West, predictions we now know to be greatly inflated. The committee appointed by the UK government in 1988 predicted UK AIDS figures for 92 that were over double what they turned out to be. In fact, the only scientist who has consistently predicted almost exactly the right figures for the UK is Professor Gordon Stewart.
Because those predictions are so erroneous, and because the methods used by and large are the same, I find it very hard to understand why they place such confidence in those estimates for Africa, even though the confidence limits are wide. I mean, at one extreme they'll say very small number, the other extreme a very large number, and saying that it's not easy in between to decide what's going to happen. But that makes it all the more important to avoid making those statements about the statements of doom about whole populations being exterminated. I can't see at the moment that we have justification for saying this.
Dr. Harvey Bialy, who has lived and worked in Africa, is deeply skeptical of any current AIDS claims about the continent.
Those claims are just that. They are based on no real evidence whatsoever. In fact, the evidence could not really exist because mortality figures for the continent of Africa have never been kept as matters of record by the governments, even within hospitals. These figures are extraordinarily difficult to come by.
One group that is being closely observed is the prostitutes of Abidjan. Research shows a much higher incidence of HIV than in the rest of the population. Some of the women have been falling seriously ill and some have died. But prostitution often goes hand in hand with hard drugs, and Abidjan's recent tourist boom has helped finance an escalating drugs problem. As yet, there's no useful evidence as to whether the prostitutes are dying of HIV infection or drug addiction. Côte d'Ivoire's Committee for the Fight Against AIDS has just started a project amongst prostitutes.
Dans le milieu, c'est vrai qu'il y a beaucoup de problèmes avec les drogues. Nous-mêmes, nous faisons beaucoup attention pour ne pas bloquer le travail que nous voulons faire avec ce groupe-là.
Ils fument cocaïne et héroïne, n'est-ce pas?
Oui.
Ils le fument.
Mais le hashish est la drogue la plus fumée. La cocaïne s'introduit sur le terrain de plus en plus, mais l'héroïne, c'est très contrôlé quand même. Hein. C'est très contrôlé, mais vous savez, dans ce milieu, on ne peut pas tout maîtriser.
Many prostitutes, like Alice from Ghana, are not convinced that it's sexually transmitted HIV that's killing them. They believe it's the drug addicts among them who are dying, like the story of a Liberian friend who was diagnosed with AIDS, or SIDA, as the French call it.
Drug. She took drug too much.
So what happened? She was sick?
Yes. Smoking the drug, didn't chop. No chop.
So she went to the hospital?
Yeah.
And then what happened?
And no half medicines. She died for them.
She died? Why did she have no medicines?
No half money.
No money?
No money.
So she died?
Yeah.
And was that SIDA, do you think?
No.
What was it?
Then, so the SIDA, the doctor can change the SIDA. It's not SIDA.
You don't think it was SIDA?
No, no, no.
What do you think it was?
Drugs.
These girls are consuming hard drugs in a smokable form, namely heroin and cocaine, in vilely adulterated versions for the first time in the history of Africa. And these drugs began to make their way into Abidjan in 1985-86. They are epidemic amongst certain classes of prostitutes right now, and these are the only girls that are getting sick. It looks like AIDS because these girls are wasted, both because of the direct effects of the drugs and because they use what little money they have on drugs rather than on food.
Investment in AIDS research in Abidjan has led to extensive testing for HIV. Projects like this one at a maternity clinic in Kumasi have shown a greater incidence of HIV in Africa than in the West. But what they don't seem to be showing so far is a frequent progression to AIDS. That's only the first of the puzzles. 80% of the HIV-positive mothers at this clinic are perfectly well. Jeanette, for example, who's visiting the clinic today for a regular checkup and blood test for her baby Anne.
Bon, disons que de façon générale, ces deux dames que nous venons de voir ce matin sont asymptomatiques. Elles ne présentent pas de signes de sida. Mais le problème, c'est qu'on ne sait pas depuis quand elles ont été infectées. Là où nous sommes un peu gênés, c'est le fait que nombreuses parmi les femmes qui sont classées comme négatives remplissent ou du moins respectent la définition du sida.
The study's director, Dr. Georgette Lolo, has noticed that in the HIV-positive group there are marked differences in progression to AIDS.
Il n'y a pas de doute que le virus HIV est la cause du sida. Mais nous observons des différences dans la progression. Et avec ces observations, je peux penser que non seulement il y a le VIH, mais il y a certainement certains cofacteurs qui accélèrent l'évolution vers la maladie. Et peut-être d'autres facteurs comme des facteurs nutritionnels, des infections intercurrentes.
Le virus n'est qu'un cofacteur, donc on peut peut-être penser que ne fait pas un sida qui veut, que beaucoup de personnes peuvent rencontrer le virus de l'immunodéficience humaine, mais parmi ceux-là, certains feront un sida, d'autres n'en feront pas. Donc il faut penser qu'il y a plusieurs facteurs que nous devons identifier pour améliorer notre compréhension de la maladie et améliorer aussi la manière dont nous voulons lutter contre celle-ci.
The more research funding that's put into Africa, the greater the anomalies that emerge. Does HIV need triggers to turn into AIDS? Can you have AIDS without HIV? Can you live with HIV and not get AIDS? Our search took us on to Cameroon. The 7th International African AIDS Conference held in Yaoundé, Cameroon. Here the emphasis is almost exclusively on controlling AIDS by controlling the sexual spread of HIV. The conference attracted over 2,000 delegates from all over the world. Although AIDS was first diagnosed in the United States in the early 80s, many still look to Africa for the origin of the disease, blaming the African green monkey and African sexual practices. But as more is understood about the disease, the Western model of AIDS seems to have less and less in common with AIDS in Africa. In the West, 90% of its victims are male. In Africa, nearly half of the diagnosed cases are women. Blaming Africa for AIDS caused puzzlement at first, and then outright anger amongst many Africans.
There were many examples, but one example is that Africans gave their children dead monkeys to play with as toys. And there was all this nonsense about how promiscuous Africans were than any other humans. I mean, I could go on and on. I mean, and that Africans believed that the only cure for AIDS was to sleep with virgins, and this is why AIDS was so widespread in Africa. Most of them were all based on racism or racist preconceptions of Africans. The allegations really that Africans were more promiscuous than the rest of the human race were unfounded. They didn't make any sense scientifically. In fact, when they sent teams of researchers, sociologists, anthropologists to Africa, they were amazed that Africans were actually much more conservative in their sexual practices.
A focal point of the conference was the need to change sexual practices and how to encourage the use of condoms.
Okay, you see there's the tank. This is the tank where the sperm will remain after ejaculation. You hold like this, and gently it goes down. Make sure this one, you press the tank, gently, and there it is.
The Cameroon conference was a grand affair, drawing together all the national and international dignitaries of the AIDS round. But behind the scenes, a French charity worker called Philippe Creenan was photocopying his protest pamphlets down the road. Pamphlets critical of the AIDS hype he has experienced in Africa. He's angry at the way exaggerated figures for the prevalence of HIV in his area of Tanzania are causing distress and even death in his communities. So he decided to test an entire village and called a press conference here in Cameroon to announce the results.
And we got the whole village coming forward to volunteer to know what? To know if they were going to die. What is important is to see that these declared AIDS cases of deaths have not increased. This village particularly, since 2 years.
We went to visit Philippe across the Ugandan border into the Kagera region of Tanzania. Philippe was waiting for us across the border. He is director of Partage, a French charity that supports, through individual sponsorship, orphan children in this remote region. Orphan in this part of Africa means a person under 18 who has lost one or both parents. It can also refer to children with special needs. Philippe travels constantly and has noticed that the number of so-called AIDS deaths is diminishing in this area.
We see that the casualties because of AIDS with the diseases which are called AIDS here, which are similar to the symptoms of AIDS, they are less and less since now 2 years.
Philippe and his wife Eveline have based themselves in Bukoba, a once prosperous town on the edge of Lake Victoria that has fallen out of political favor over the years and is suffering increasing poverty and neglect. Here, Partage provides medical care, schooling and support to children in 15 villages spread over a vast region spanning over 1,000 square miles. So great has been the fear of AIDS in this community that Philippe has found it difficult to generate community support for the orphan children.
How can you ask people who believe they're going to die tomorrow, how can you ask them to look into the future, which are the children? They give up. They don't invest. They don't want to come to work in northern Kagera because they think they are going to die of AIDS or to contract it.
HIV awareness campaigns have been particularly successful in this region, leading most people to believe they could be infected. Philippe decided to get at the facts. First, he asked all of his 160 workers if they'd volunteer for confirmed HIV tests. He found 5% were positive. Then a whole village of 842 people volunteered. He found 13.8% were positive. These figures are higher than estimates for the number of HIV positives in the West, which are less than 1%, but substantially lower than previous estimates for this region of Tanzania.
It is the first time in Africa that a village has volunteered as a whole to be tested for a dreadful disease, that everybody has got its results, and that the truth has been 5 times lower than the figures given by the World Health Organization of the AIDS control programs.
Rebuilding the shattered confidence and morale in this region has required dedicated follow-up. Lucy is an orphan who was working as one of Philippe's trainees. She became ill with repeated infections and lost over 20 pounds in weight. Most people thought she had AIDS.
Nilianza kuugua kipindi kirefu. Alafu kipindi kilichofuata Mr. Philip alikuwa amekuja kwa ajili ya kufungua kituo Maimbele na akamleta mpaka kwetu, ndipo aliponiona kwa naumwa kanipeleka Mgana.
Philippe discovered that Lucy had been diagnosed as HIV positive in an unconfirmed screening test. He and his wife decided to support Lucy and help her regain her position in the community. They moved her out of her small hut and built a new house for her.
Slowly, in 4 or 5 months' time, Lucy started to recover, to put weight, supplemented with vitamins, supplemented with food, with a better salary. And because she had put weight again and she had been freed of skin diseases, her friends started to look at her a bit differently. Not putting her on a side and not being afraid of her, because they started to question if really she had AIDS or not. It's very seldom you see people who have been stigmatized with AIDS who are not dying a few months later. So Lucy was one of the first persons who, because we didn't support the AIDS tag on her, recovered and was the proof to the community that you can recover from such episodes.
Ninavyofanya kazi na ninavyojisikia hali yangu ni nzuri kama mwanzoni nilivyokuwa kabla sijaumwa.
What would you like to see happen?
Kabla nategemea hapo baadaye kuzaa watoto.
In 3 successive tests, Lucy has now been found to be HIV negative. She's just one example of the mass of flawed HIV statistics that bedevil Africa. Her unconfirmed screening test would have been included in the official reported figures for HIV positives.
Some of these tests are so non-specific that 80%, 90% of the positives that are picked up are in fact false positives. They're reacting to antibodies that are not HIV specific. And when one realizes that these tests are being pushed in a context in which we have to test as many people as possible, the inevitable outcome is that Africa, the figures for numbers of HIV infections in Africa will become wildly exaggerated and feed into a very, very deadly self-fulfilling prophecy.
According to official figures, over a period of 8 years in the United States, there's been a relatively stable estimate of 1 million HIV-positive people. The total number of reported AIDS cases is 250,000. In sub-Saharan Africa, as testing has increased, the estimated HIV-positive total has risen to 6 million people, 6 times the US figures. But the total number of reported AIDS cases is only 129,000, half the US figure. The disparity between HIV and AIDS here and in the West is dramatic, but the single most obvious fact about AIDS and HIV statistics in Africa is that they're unreliable and virtually useless in charting the course of African AIDS. HIV figures are flawed because the tests are unreliable, giving too many false positives. And identifying AIDS through the Bungay case definition by looking for a combination of several symptoms is also flawed because so many other diseases get swept into the net. Does the African experience of AIDS help our understanding of AIDS in the West? One who thinks it does is molecular biologist Professor Peter Duesberg. He has argued for 6 years that HIV is not the cause of AIDS. In leading science journals, he develops his view that HIV is no more than a passenger or hitchhiker that's around like other bugs when people are at risk, a bug that's dormant rather than fatal. And he points to one anomaly in particular in Africa's statistics that he believes supports his theory: more than 2,000 documented cases of AIDS without HIV. Many of these cases came from Dr. Kevin de Kock's studies in Abidjan's 3 main hospitals. There, over 1/3 of cases not qualifying as AIDS under the Bungay definition of symptoms were HIV positive, and 1/3 of the cases which did qualify as AIDS were HIV negative. How does Dr. de Kock explain the cases in his study which have been diagnosed as AIDS cases but when tested have been found not to have HIV?
If we're talking about AIDS, we should perhaps scrap that word and talk about HIV disease, all right? It's very clear what is HIV disease. Now, it is not surprising that the constellation of symptoms, signs, and indeed opportunistic infections occasionally occur in people without HIV infection.
There are thousands of documented cases from the third world, from Africa in particular, of clinically reportable AIDS in which HIV testing has been done and found to be negative. I think it's amongst the strongest arguments that HIV is irrelevant to the development of AIDS in at least some cases, if not all cases.
Dr. de Kock maintains that those HIV negative cases may have looked like AIDS, but they were simply similar conditions which were drawn into the net when collecting numbers of patients for research purposes, not for patient care. These 2,400 cases were called AIDS for all intents and purposes in all the literature, and yet you're saying they shouldn't have been called AIDS, but they were identical to AIDS. So
but they were HIV negative.
2,400 misdiagnoses.
Are we talking about, we're talking about the quality of surveillance data?
The documented cases of full-blown AIDS, which when tested, were HIV negative.
Well, then they're not AIDS cases. They're not AIDS in the way we talk about HIV disease.
But they were called AIDS in the documents. They were called clinical case definition Bungay AIDS. Do you see?
Of course I see. Any case definition, particularly one which is clinically based, is not going to be perfect.
When one has clinically identical pictures, one with HIV antibodies, one without HIV antibodies, to call one AIDS and one not AIDS is patent absurdity. This is irrefutable proof that HIV is not necessary for the presence of AIDS, except by definition.
In Uganda, the external debt now stands at $570 million. The interest payments on these debts amount to twice the total annual health budget, which is about half of 1% of the gross domestic product. There's a crying need to call on health funding from outside. The trouble is, HIV prevention is swallowing most of it up. In 1992, Uganda's total budget for malaria treatment and control was less than $57,000, yet foreign funding for AIDS was over $6 million. However well-intentioned, AIDS funders also have their own agendas. The American government's aid agency, USAID's genuine desire to help prevent the spread of HIV by funding counseling and condom distribution coincides with its declared interest in population control. Its investment in HIV prevention is huge.
In the next 5 years, AID plans to devote hopefully as much as $400 million for prevention activities worldwide. Much of that will go to Africa to help develop larger, more comprehensive and integrated programs that we hope will be able to show to the world that you can make an impact on behavior change, and we can make an impact on slowing down the spread of HIV transmission.
There has been some strong criticism that USAID's policy in Africa of distributing condoms suits USAID's policy for population control, and this is worrying some African spokespeople. What is your view?
Well, AID has always had a very strong emphasis on population, but condoms have never been the contraceptive of choice for population programs, and so condom use in population programs has not been particularly successful.
We have about more than 700 non-government organizations operating in the AIDS field in Uganda. This raises a lot of concern because a few of them are doing a very good job, but a good number of them, my ministry is not aware of what they are actually doing. And there is no way of evaluating them. Unfortunately, a good number of them do rush in, collect data, and go away with it. And the next we hear about it is when it is being printed in journals, and we have not had any input. And some of this work has been done in very limited areas, not reflecting the rest of the country.
At Mulago Hospital, senior lecturer Dr. David Sawada is not at all happy with the way research projects have been conducted in Uganda, and in 1990 published his criticisms of Western researchers in The Lancet.
I'm concerned about who is setting the priority. 2, the main results, the implications of the results, how applicable are they, and how relevant they are to our environment. And 3, the training of during the course of this execution of the research, a training to train the local individual so that at the end of the research there is some local manpower that is trained to be able to carry on independent research.
Dr. Sawada has told us he keeps an open mind as to whether HIV is the cause of AIDS, and is conducting his own research in the Rakai district with a team from Mulago Hospital. Contrary to previous reports, he's found a lower than expected incidence of HIV at 12.6%, almost the same as Philippe Crenan's findings in the neighboring region of Tanzania. Another of his projects involves following up 100 discordant couples where one partner is HIV positive and the other negative.
The results of this study so far shows that in only 5 pairs have both individuals become positive. This was a pleasant surprise because we had expected a much higher seroconversion. Which means both couples becoming positive over a 2-year period.
If HIV were one day found not to be the cause of AIDS, then the consequences for Africa and Africans of following the HIV hypothesis would have been grave indeed.
What keeps a man energetic and keeps him doing what he does is the hope for the future. But once you tell me that I am HIV positive, then you have given me this message that you are going to die, and therefore I have no energy for the future.
In spite of everything, life and love goes on in Uganda, and even those who believe HIV does play a role in AIDS have strong messages of hope for the future.
You see, the majority of our people here are children who are below the age of 19, and these are more than 50%, and they're all negative. Most of them are negative. If you look at the seropositivity incidence, the prevalence of AIDS cases here in this country, which supposedly is the worst hit, you'll find that not more than 6% of the general population is affected. Now, 6% leaves 94% of the population completely able to perform what should have been done by the rest of the population. So I don't think AIDS really, in the long run, will completely mutilate and disintegrate Africa.